Welcome to part 4 of the training program. In this last part, we are going to talk about how to work as a team to get meaningful activities in place and working for residents with dementia. As before, we suggest that you keep the handouts for this part nearby so that you can easily refer to them. There are two main learning objectives for this part of the program. First, we are going to review the roles that are commonly needed to effectively implement and monitor individualized activities for older adults with dementia. Then we will describe some basic principles for implementing activities. The CMS activity rule that we talked about in part 1 is full of great ideas. In many ways, it tells facilities and staff what to not do. As noted on the slide, the rule is saying this isn't good enough. Activities need to be person appropriate, and for those with dementia, staff need to develop and implement one-to-one or individual programming that meets the person's individualized needs. Activities have to occur throughout the day, be documented in the care plan, and understood by all team members. And while the activity rule gives some guidance about how nurses, nursing assistants, social workers, and the activity or recreation department should plan to be involved, it doesn't give any real advice on how to work as a team. We know from both experience and research that successful activity programs are based on teamwork, and that the team includes a wide variety of people, from residents to those we most often think are responsible, activity and recreational therapy personnel. Although the CMS rule specifically names some team members, others are equally important. For example, the facility administrator and the director of nursing need to support the team and help them work together on projects. Other therapies, like physical, occupational, or speech therapy, may be needed to help conduct an assessment or develop a specialized activity to meet physical or cognitive needs. In other instances, assistance from the dietary department may be needed to implement therapeutic cooking activities, and orders from the primary care physician may be needed for some things. We can also never underestimate the important contributions of residents and family members. In short, it takes the cooperation of a pretty diverse group of people to get things started and keep them going. We don't have time in this short program to tell you exactly how to work as a team, but we can tell you what successful activity teams often do. First, they have the backing of their administration to form an interdisciplinary team that meets on a regular basis. Successful teams regularly include all available disciplines and key staff that are needed to make changes. Identifying a leader, a person who is knowledgeable about activity involvement and dementia care, is important. Developing specific activity-related methods and processes that fit that nursing facility's unique needs is important, and so is communicating regularly with others in the nursing home. Successful teams and programs also build on the strengths and abilities of their members. The discipline of the team member, like nursing, social work, or activity or recreation, is less important than the staff member's interests and abilities. For example, a nurse who is also an expert in relaxation may be a perfect leader for a relaxation activity. A nursing assistant who sings or plays a musical instrument may lead music programs. The point is to build on staff members' interests and abilities, so if staff really dislike group work or playing games, try not to put them in that role. Give them something else to do. Being successful will rely on answering a number of important questions. The regulation itself is quite clear about the requirements for being in compliance with the activity rule. What is not clear is how individual facilities will adjust expectations, roles, and responsibilities to assure that those requirements are met. Every facility is different. In too many situations, caregivers don't think about activity involvement as their job. That's something the activity or recreation department does. And often the activity or recreation department does take the leadership role, but nurses need to make sure that other appointments or demands don't interfere with a person's program of activities. And nursing assistants need to get people ready to participate and provide help to get to the activity and identify when, as needed, intervention should be used. Cooperation within and between departments is essential. Being successful will likely rely on answering those questions. Who will do what? Understanding some basic principles for implementing activities is also important to success. As the slide and handout note, a number of factors should be considered in planning activities. As emphasized in Part 2, activities should be tailored to meet individualized abilities and needs. For example, will the person need one-to-one individual activity before joining a small group? Is a large group appropriate at all for the person? As you think about group activities, ask yourself, what size of group is best for the topic or activity? How many staff are needed to help persons with dementia be successful? What kind of cueing or supervision will be needed? Remember, the goal is for the person with dementia to do the activity on his or her own, not watch a staff member. Just like physical therapy, the person, not the physical therapist, does the exercise. The therapist instructs, supports, and encourages. The same is true for activities. Other considerations include the mix of older adults. For example, which level of ability is reasonable to include? Is the activity targeted at low, moderate, or high-functioning persons with dementia? And within the group, how will the personalities and characteristics of group members blend together? The point is to put people together in ways that will be successful and enjoy themselves. Part of the decision is who to include, and the other part is developing strategies to work with those who tend to dominate, cling, and sit passively. Matching activities to the needs of persons with dementia requires a good understanding of daily rhythms and routines. Both passive and agitated times of day should be considered. Each has its own set of problems, and each can be considered as part of the individualized activity plan. Think about when behaviors occur and time activities to fit the person's needs. Remember, the same person can be passive and agitated in the course of the day, so plan accordingly. That includes developing as-needed or PRN activities, like simple pleasures, to offer when activity or recreation staff are not present to help, in the evening and night, over the weekend, or during transitions throughout the day. Many residents can be engaged in self-directed activities with the right type of help, but that relies on knowing the person's interests. For example, some may enjoy looking at a magazine or catalog that relates to their interests, like fishing or gardening. Simple pleasure items, like sewing cards, may be a great choice. Remembering to seat people near one another is often effective, particularly those who like to chat. But take time to get the conversation going. Start the dialogue by finding some shared interest or introduce a simple game like dominoes or checkers. One-to-one individual activities with staff are important, but need to have a goal. For example, a withdrawn person may need special assistance to get started in a simple activity, like a game, with a staff member. However, the goal is to help the person eventually play the game with other residents. In a similar way, an agitated resident may need one-to-one assistance to find an activity that is comforting and not too stimulating. But the goal is to reduce the risk of agitation by making the activity part of the daily routine. One of the most important contributions to activity involvement is being available and ready when the activity starts. Being ready means being dressed, groomed, and toileted with eyeglasses on and hearing aids in place. It also means being fed, given a drink of water or juice, and being dressed appropriately for the activity, like wearing sturdy shoes for a walking program or a hat to garden. This preparation is very important, but not often considered. Nurses may need to adjust the medication schedule or doctor's visits to make sure the person can fully participate. Giving as-needed pain medication before the activity, particularly ones that involve exercise or movement, is another important consideration. We also need to think about getting to the activity. The person shouldn't be exhausted when they arrive. The physical environment is also important to being successful, particularly for persons with dementia. Being comfortable and free from distractions is essential. Things like the size and location of the room, seating arrangements, room temperature, and access to comfort measures like refreshments or going to the toilet are all important. We suggest that you use the checklist in the handout to help you think about environmental factors that often influence outcomes. Staff approaches are critically important to the success of any activity. Self-directed, one-to-one, individual, or in small groups. Instructions to get started need to match the person's level of ability. For example, the person who has more severe cognitive impairment may need more cues to get started. Likewise, a person who has difficulty seeing or hearing may need special assistance. Being a role model for the activity also helps. For example, staff should wear walking shoes, like sneakers, and perhaps carry a walking stick for the outdoor walking program. Role modeling also applies to getting people started in the activity. Show them what to do, but without taking over and doing things for them. Remember, the residents should do more than the staff. The staff member's job is to instruct, demonstrate, and prompt to get things going. Encouragement and cues like "good job" and "try this" should be failure-free. Saying things like "oh, not like that" is another way of saying you are wrong, and that is not helpful to building confidence and self-worth. In fact, this type of negative feedback is believed to contribute to problem behaviors and should be avoided in all aspects of dementia care. Using basic communication principles is another important consideration when engaging older adults with dementia in any activity. Busy care providers may forget how simple courtesies, like introducing yourself, can make a huge difference. Try treating the person with dementia like you would a guest at a party you are hosting. Greet them, shake their hand, help them feel welcome, introduce them to other participants. Use eye contact and nonverbal support like nodding, gesturing, and smiling, along with simple instructions and cues. As before, tell them what to do versus what not to do. As outlined in your handout, the same basic communication principles that are used in dementia care apply when conducting activity programs. Slow it down. Keep it simple. Ask one question at a time and wait for an answer. Make the best use of nonverbal communication like pointing, gesturing, smiling, nodding, and other forms of encouragement. Instructions should be simple, brief, and understandable. The goal is to get the participants to talk and engage in the activity. Remember, a moment of silence may be needed for persons with dementia to gather their thoughts and speak, so don't feel like you need to fill in the gaps. Staff should also avoid talking to one another about things unrelated to the program, no matter how urgent it may seem in the moment. The unrelated discussion implies that the activity at hand and the residents present are not important. Although you don't mean it in that way, that's often what participants feel. Being prepared for outcomes that aren't expected, like a participant being agitated or trying to leave the program, is important. In some cases, using a simple pleasures item will help calm and soothe the person. In other cases, it may be better to quietly remove the person and assess them for possible needs like toileting. The opposite of agitation, sleeping through the program, is another signal that the activity is not meeting the person's needs and should be adjusted. Methods to bring an activity to a close and to transition participants to other activities are just as important as engaging them at the beginning. Give participants a warning that the activity will soon be over. Say goodbye and see you again soon, and then help them transition to something else. Transitioning to something else is critically important. Never leave the person without something more to do, something to hold, to look at, or to interact with. There are lots of choices. In fact, maintaining involvement before, during, and after formal and care-related activities is both tremendously important and consistent with the CMS activity requirement that activities are ongoing. Providing people with something to do while waiting for meals, family visits, or other events, to be returned to their room after an activity, or while waiting for personal cares, is an important part of their overall program of activities. As noted on the slide and in the handout, there are lots of choices. Providing activities during care is also important, like a wave machine while getting medications or a squeezy during medical or dental visits. Redirecting the person's attention to something that is interesting and hopefully comforting may reduce the risk of negative behaviors. And as before, include things for residents to do after care or small group activities. Many of the simple pleasures items described in Part 3 are perfect choices for these transitions. The point is that we should not leave the person with dementia without something interesting and engaging to do. The person's level of involvement in the activity, their reaction, positive or negative, is a great starting place for evaluating success. Health-related outcomes, like the person's level of depression or anxiety, their functional level, and certainly the number and type of behavioral and psychological symptoms that they experience, are also good indicators to monitor. Asking the person with dementia and their family members about their satisfaction with the activity program is another important outcome. People with dementia are often able to tell us more than we might expect. So ask, did you like this? Do you want to do this again? What else would be fun for you to do? We have nothing to lose and lots to gain by trying. Making adjustments to the selected activity related to the length or how complicated the activity is, or even changing from a small group format to a one-on-one approach, may be needed to help the person be successful. For example, falling asleep may only mean that the program was too long, or it was provided at a time when the person is naturally sleepy, like after lunch. In most cases, short programs are best. But as before, don't leave participants with nothing to do. Be sure to transition them to another interest. In summary, developing and maintaining successful, person-appropriate programs of activity for persons with dementia relies on the cooperation and assistance of all team members. Each team member makes a contribution, starting with assessing the individual's residents' needs and preferences through planning and implementing selected activities, evaluating outcomes and adjusting the course as needed to best meet the person's individualized needs. There is one last workplace exercise to be completed. Please locate the Part 4 exercise in your handouts now and follow the instructions provided there. Completing that exercise will conclude this dementia training program. Once you are done, take time to complete the program evaluation that accompanies the program. Your feedback is important and greatly appreciated.